Hi, my name is Elliott Sherr. I'm a neurologist at the University of California, San Francisco, and I'm one of the principal investigators of the Simons VIP study. As you know, we've been focusing our attention on individuals who have two chromosomal disorders. One is deletion or reciprocal duplication at chromosome 1q21.1. And I'm going to talk today about the neurologic findings associated with that condition. This is a recorded webinar, so it won't be possible to do interactive question and answer, but you're welcome to contact the foundation, and I would be happy to field any questions by email. So just to begin, and I apologize, there's a technical error right here at the head. It should say 1q21.1. We're going to focus today on two aspects of many different approaches that the investigative team has taken to study 1q21.1. And that's the neurologic history and examination. So all of you, or many of you, went to one of the 5 sites, including Seattle, San Francisco, Baylor, CHOP in Philadelphia, and Harvard and Boston to be evaluated. And a neurologist took a clinical history and did a physical examination, and also asked questions about epilepsy that may be in the child or in the family. And all of that data has been accumulated and analyzed, and I'm going to highlight some of the features of that in the remainder of this webinar. So what I have listed here is the number of individuals who were both deletion and duplication carriers. And so that's up here, number of 18 who have deletions and number 19 who have duplications. And then of those 18 and 19 individuals, below in the column, we've listed how many individuals in that group had one of these neurologic features that are listed over here in the left column. And so some of these include things like tone that we find significantly elevated in individuals who are deletion and duplication carriers. You can see there's increased hypotonia, as well as head size, so macrocephaly meaning a large head, and microcephaly meaning a small head, and other disorders such as cranial nerve disorders, and down here at the bottom, what we call unprovoked seizures or epilepsy. So the first one of these features that I'm going to highlight is macrocephaly, and macrocephaly just simply means an enlarged head. However, usually macrocephaly, an enlarged head, is associated with an enlarged brain on the inside. And you can see here in A and B, you have the same child. This is not a 1q21 patient, but this is another child who has a head that's larger than normal. And you can see that it's extending beyond the eyebrows in a term that we call frontal bossing, because there's that extension of the cranium. And you can see here in B that it's longer from front to back. And so this is one example of macrocephaly. The way we determine that is by very simply putting a tape measure around the head, measuring the circumference from the front to the back. and sometimes that's referred to as OFC, occipital frontal circumference. And over here in the chart, we can see a number of lines, and these lines represent different percentiles in the general population. So the top black curve here refers to the 95th percentile, and that means that if you have a measurement of head size that's above that line, that only less than 5% of individuals have a head equal to or bigger than yours, or conversely, 95% of the general population have a head that's smaller than yours. And at the bottom here where it says 5, the opposite would hold. Anyone who had a head size that was below this line would have a head size that was smaller than 95% of the general population. What I've drawn here in red is a growth chart for an example patient who has macrocephaly. And in this case, you can see that the line starts above the 95th percentile and stays above it throughout that time course, in this case essentially from birth to 9 months of age, that this it remains above. Sometimes individuals begin their head size below the 95th percentile, and then that exceeds the 95th as the heads grow. But usually individuals who have big heads often have big heads at birth. So the inverse of that is microcephaly. And so you can see here, again, in this cartoonish picture of a head, you can see a normal-sized head and a normal-sized brain contained within it. And then here you have an individual who has the same facial contours as the child to the left, but has a smaller head, and this would be microcephaly. And then again, I've displayed here in red a growth chart for the first 9 months of life of a child who would have a smaller head. Okay, and the other thing to notice is that deletions and duplications actually, as a general rule, have a reciprocal macrocephaly and microcephaly. And so displayed in red here are individuals who have the deletion, and except for this one outlier right here, all of the individuals who have a deletion have a head that's smaller than average. So head circumference z-scores, this is just basically a way of displaying the size of a head relative to the general population. So if you have a score of 0, that means that you're completely average. If you have a score of -2, that means -2 standard deviations. So this would be equivalent to the 95th percentile, or the 5th percentile, however you want to view it. And then -4 is greater than 99th percentile. And so you can see that while some deletion carriers don't actually have a small head, meaning smaller than -2 standard deviations, all of them are mostly distributed across this microcephalic range. And then by contrast, the inverse, the duplications, again, are associated with a larger head than average. And again, there's some outliers over here. So while each individual may have his or her own head size, as a general rule, the deletions of the 1q21 patients have smaller heads, and the duplication carriers have larger heads. Okay. Another feature that is commonly seen in individuals with 1q21 are seizures. And you can see here up at the top, 3 of 17 individuals who are deletion carriers had seizures, but none of the duplication carriers had seizures. And again, if you remember, the deletion carriers have the microcephaly. and so suggesting that maybe microcephaly is more likely to co-occur with the deletions. And electrically, what I've shown here is what we've labeled as a normal EEG, and so each one of these squiggly lines represents a different location in the brain. And so up here in a schematic is the different electrodes that are placed evenly across the head, and each one of these lines represents the electrical difference between one point and a point adjacent to it. So typically this top one here would be FP to F4, and then the next one would be F4 to F8, and so on. And there is a lot of variation in electrical activity. Some of them are smaller amplitude waves, as you can see here, and some of them are larger amplitude waves, as you can see here. But this is a normal EEG. In contrast, this is an EEG of a seizure that's happening. And so you can see here at the top that you have, again, a variety of frequencies of electrical signal. Some of the waveforms are a little bit bigger, some of them are a little bit smaller, and they're alternating in this space. But you can see down here that in both this middle grouping of waveforms as well as this lowest grouping, that there is a dampening of electrical activity for just a moment, and then as that dampening ends, you can begin to see a highly rhythmic pattern that is increasing both in amplitude as well as possibly even over here in frequency. And that's something that you typically see in a seizure, where there's a focal onset, and then over time that electrical activity spreads either just in one hemisphere in the brain or actually throughout the brain. And so this is what a seizure looks like on an EEG. In this next slide, I'm going to show you an example of an adult individual who was a patient at UCSF who agreed to have his seizure shown for educational purposes. He has what's called a focal seizure with secondary generalization. And so what that means is the electrical activity that results in a seizure starts initially in one part of the brain and then over time spreads to other parts of the brain. Clinically, what you will see is a person who appears to be agitated, and actually that agitation is in response to a seizure starting off only in a small part of the brain, and then over time you'll see that that seizure evolves, it changes, and what happens is the individual will have larger involvement of more of the brain, and he'll show both stiffening of his muscles, both in his face and in his arms, and then you'll see what's called clonic or rhythmic shaking. Okay, let's go ahead and watch this video.
In that, although it begins with confusion and the other automatisms we've seen previously, this also, after a period of time, spreads into deep parts of the brain, and he goes on to have a frank tonic-clonic seizure that has secondarily generalized from the partial onset.
And then he's turning his head, and that's actually an involuntary turning of the head caused by the seizure.
And now we're into a typical tonic phase of the attack with his arms stiffly extended, and the same is commonly true of the legs at the same time. This lasts perhaps 10 to 15, 20 seconds, and then begins to slow progressively into the clonic phase of the seizure.
The clonic shaking.
Again, this gets slower and slower, and then after about another 15 to 30 seconds, will stop. During this part of the attack, the patient may bite his tongue, may have
as a tonic clonic seizure. So tonic meaning the stiffening, and then clonic meaning the shaking. And that order, starting out with stiffening and following up with shaking, is something that we see very often. The next seizure type that I'm going to show you an example of is something called infantile spasms. So this is something that is seen in a number of children with neurodevelopmental disorders. These seizures often occur between 6 months and 1 year of age, and they're frequently small motor seizures, either what look like drop attacks, and I'll show an example of that, or stiffening or myoclonic jerking. These are often seen as clusters of seizures, one after the other, so there'll often be 4, 5, or even 10 or more seizures in a row, each one lasting less than 15 to 30 seconds. And sometimes, but not always, the children can appear to be quite irritable in between the spells. The one that I'm going to show you here is a more subtle example with a child that appears to otherwise be clinically well while the seizures are happening. So at the beginning, there was a head drop with an arm extended, and that was actually a seizure.
Matthew.
Chiquitín. Hey, Matthew. Hey,
and there he repeated that activity where his head dropped.
See, he's not responding to my voice. Matthew. Matthew. Matthew.
Okay, so those are 3 examples of that one child having repetitive infantile spasms. Okay, so in addition to seizures, patients with and macrocephaly or microcephaly, patients with 1q deletions and duplications can sometimes have tone abnormalities. And you can see that up here that we've listed hypo and hyperreflexia. And I'll show an example of that in just a moment. And also examples of tone abnormalities. So this is a testing for truncal tone. And so this is taking a newborn and placing the newborn on your hand and seeing whether the infant will try to remain in a straight position, which is what you see here on the right. And this is normal tone. The baby's head is elevated, and the legs are in a flex position, and the back is straight. In this child here over on the right, over on the left, you can see that the back is curved. The baby makes no attempt to elevate the back and keep it straight, and the head is also drooping down. And so this is an example of hypotonia, and you can see displayed here at the bottom that approximately 1/3 of deletion and 1/3 of duplication carriers have hypotonia. So this is quite common. There is another form of hypotonia that you can also assess for, and this is referred to as head lag. Again, what the examiner is doing here on the right is just simply grabbing the baby by the forearms or by the hands and gently pulling the baby up from a supine position, lying on his back. And you can see here that the baby is able to exert energy to keep the head in a neutral position relative to the rest of the body. And then here on the left, for a child who has fairly significant tone abnormalities, this baby is not able to maintain his or her neck in a neutral position but rather allows the head to flop backwards because no motor control is demonstrated. It's sometimes hard to tell the difference for this, whether it's weakness or decreased tone, as there's oftentimes an overlap. But you can clearly see here with the head lag test that this child on the left has hypotonia and this child on the right has normal tone. Okay. In addition to tone, we can see changes in reflexes, and reflexes are simply how tone is set in the body. And you can see examples of both elevated reflexes or hyperreflexia. And I'm not going to show you here, but the inverse would be hyporeflexia. Okay, so this is a doctor.
We'll be careful on this side. Okay, so L4.
And he taps on the patella.
Okay, and look, we have some clonus in the leg.
On the patellar tendon. And
we
you
can stop it by pushing on the Golgi tendon organ just above.
For quite some time before it stops. I'm going to play it one more time here. And you can
we'll be careful on this side. Okay, so L4.
And actually continues to bounce.
Okay, and look, we have some clonus in the leg.
And that's an example.
We can stop it by pushing on the Golgi tendon organ just above.
In the next video, I'm going to show an example of a tic. A tic is a repetitive, involuntary movement. You've probably all heard of the term Tourette syndrome, and Tourette syndrome is just basically a syndrome with a complicated mixture of different kinds of tics, including motor tics, and particularly including cognitive or behavioral tics. And this child here that I'll show you as an example of a motor tic in her mouth. Okay. All right. Just to summarize, we've talked about multiple aspects of the neurologic exam on individuals not with 16P, but with 1q21.1. And we've also focused specifically on epilepsy as part of that picture. There are lots of other components to the evaluation, and there are other webinars that address those, including over here on the right, the brain imaging changes that we've seen in these two groups of individuals. Let me just close by saying that this has been an amazing collaborative effort and wouldn't have been possible without all the different clinicians and scientists who played a very substantial role in pulling this all together. And I just wanted to point out a few individuals here. Dr. Sudha Kessler is an epileptologist at CHOP, Children's Hospital of Philadelphia, and she led efforts to evaluate the epilepsy. Dr. Ramaki, Dr. Steinman, Dr. Paduri, Dr. Marco, and Dr. Spence are all child neurologists, and they have played a significant role in evaluating the neurologic findings that I've been talking about today. Thank you very much, and I hope that this was a valuable session for you.